In this podcast, we continue Chapter 7 on patient assessment, and we're going to focus on how the ABCDs are used in assessing a patient. Now, for primary patient assessment, we have to remember that there are 5 key steps to that: forming a general impression, controlling life-threatening bleeding, and then focusing on level of responsiveness and the ABCDs. Later, we'll talk about obtaining the chief complaint and making an appropriate call. So when we deal with life threats, one of the keys is to stop excessive bleeding. But then we follow up with the A, B, C, and D: airway, breathing, circulation, or disability. Life threats must be corrected before you move any further in the patient assessment process. So if we observe severe bleeding, as described before, we might use direct pressure, a pressure dressing, or a tourniquet to stop that life threat. But then we can move on to the other ideas in terms of if there's any life threat due to an airway obstruction, breathing, or disability, which is a neurological deficit. We assess these very rapidly and almost simultaneously. For the airway, we know that there are no airway problems. We say that the airway is patent if a patient is responding to us. When we achieve consent, "Hi, may I help you?" and the patient says, "Yes, please help," we know there's no problem. If there is an airway problem, say in an unresponsive patient, we need to address that immediately. That could be due to the most common airway obstruction, which is the tongue occluding the airway, or it could be due to some bodily fluid, such as vomit or blood, a facial injury causing broken teeth, or even something as simple as food or gum obstructing the airway. When you arrive on scene, the quickest way to open the airway is with a head tilt chin lift maneuver. This is what we use to ensure that the tongue does not obstruct the airway, and it's what we will learn when we review CPR. For a patient with a cervical spine injury, we can't aggressively move their skull as we would with head tilt chin lift, and so we want to use the jaw thrust method. By anchoring our hands onto the mandible, we can move the jaw away and bring the tongue with it. To move from A to B, breathing, we assess the patient's breathing by look, listen, and feel. If we see the chest rise, if we hear the sound of air escaping, or if we feel air on our cheek or on our hand as we look for rise and fall of the chest, we know that breathing is there. Now for C, we may assess a carotid pulse. It's possible that someone only needs rescue breathing in this case. To further assess the respiratory rate, we simply count the breaths for 30 seconds and multiply by 2, and this gives us the number of breaths per minute. Now, if the respiratory rate is fast, in an adult greater than 20 breaths per minute, we know that probably the patient's fight or flight response is engaged, and we need to dig deeper in terms of what might be requiring treatment. Further, we can assess the quality of the respirations, making sure that they're deep, effective breaths rather than shallow breaths that barely move the chest or some breathing difficulty. That breathing difficulty may show up by not just using the diaphragm, but including the accessory muscles of the ribs. For circulation, we can rapidly feel the peripheral pulse. For presence and adequacy, we can look at the skin color, and we can evaluate capillary refill. For an adult patient, find the pulse at the radial artery in the wrist. For smaller children, the brachial pulse is most effective. Now, if we have an unresponsive patient in cardiac arrest, our sequence changes from ABCD to CAB. And again, assessing circulation in an unresponsive adult, we don't work with the radial pulse, we'll move to the carotid artery. To find the carotid artery, put your index and your second finger on the Adam's apple, and then just roll inside toward the patient's ear until your fingers drop into a groove. The carotid artery is found just in that spot. Now, don't use your thumb. You may detect your own pulse, not the patient's. If a pulse is present but the patient is not breathing, we don't have a C issue, we have a B issue. Make sure the airway is open and then begin rescue breathing with your pocket mask or a BVM if a trauma pack is available. If no pulse is detected, basically we want to go down our CPR algorithm. Now, if a pulse is present, we hope that it's strong and regular. If it is irregular or faint, we need to find out what the underlying traumatic issue could be. To determine the pulse rate, it's the same as a respiratory rate. Count the beats for 30 seconds and multiply by 2. That gives us beats per minute. Further ways to assess circulation are just to look at the patient's skin color. If it's a normal tone, pink or dark, depending on the person's race, we know that they're probably doing pretty well. It's when we see skin that is pale or cool or clammy, or we detect cyanosis. Cyan is this root term that basically means blue, that we know we have a difficulty with perfusion. We can also assess capillary refill by pressing on the nail bed until it blanches and turns white. When we release our pressure, hopefully the color returns in less than 2 seconds. An abnormal capillary refill would be one that was slow or again was cyanotic, that is, blue. Now be advised, cold environments can cause that to be very slow to refill, because one way we keep our body warm is by restricting the peripheral blood vessels, vasoconstriction. Now the D in ABCD stands for disability, and specifically what we mean here is some injury to the nervous system. That's going to express itself as unresponsiveness, paralysis, or some neurological compromise. We might find when we rank a patient on the AVPU scale, or we investigate how alert they are and how oriented they are to person, place, time, or event, that a deficit is there. We can assess that patient for some sort of life-threatening neurological disorder, in particular those that affect the central nervous system. A peripheral nervous system problem would just affect the nerves involved in the arm or leg that maybe is traumatically injured. If a patient can feel and move their arms and legs, that is, they have sensation and motor function, we know a couple of things. Number one, they're alert because they've understood your request, and then they've purposely moved their extremities, showing that the system is intact. Now, this is just a key term to understand. Paresthesia is tingling or numbness in the extremities. Sometimes we see that especially with hyperventilation. Now, 2 very severe issues to be aware of. If we see posturing, that is either decerebrate or decorticate posturing, we know that something is very wrong with the patient. Let's look at those. Decerebrate posturing is an abnormal extension of the arms and the legs. We get plantar flexion of the feet, that is pointing of the toes, and we get arching of the head backwards. That's due to an injury to the brain at the level of the brainstem. Decorticate posturing is abnormal flexing of the arms. They bring the arms into the body. We get clenching of the fists, and this is due to an injury along the nerve pathway between the brain and spinal cord. Either forms of posturing are very, very indicative of a severe neurological deficit. Now, in this case, when we suspect spinal injury or head trauma, we need to follow protocols for spinal motion restriction. We want to keep the spine anatomically aligned and ensure that the patient does not move. In an unresponsive patient, You may not understand what the events are, so you can check with a bystander or reliable witness to help you understand and assess the situation. In that case, we would have another rescuer maintain spinal motion restriction, and if we need to, we can log roll the patient and examine the midline of the spine. Other trauma patients will continue our assessment just as they are found. One of the final pieces of primary patient assessment is to check with the patient, what is your chief complaint? What is the reason they are requesting your help? In summary, part of our primary patient assessment is to rapidly assess A, B, C, and D, and this can happen almost simultaneously for any patient. That is, if I say, "Hi, I'm with the ski patrol, can I help you?" When the patient responds, I know they have a patent airway, they're breathing, and they're likely alert. If I simultaneously put my hand on their wrist and detect a strong, regular radial pulse, I have a good sense that circulation is intact, and I may continue with further assessment. If we have any life-threatening issues, we need to make sure that we address those before moving on.